Good evening, all. So today topic is COPD. This is the anesthetic management of 65-year-old patient presenting with obstructive airway disease posted for inguinal hernia. In our practice, day to day, we generally see this type of patients, and because we have to learn how to present a case, a long case. This is a case scenario.
Yes, sir.
65-year elderly smoker, body mass weight 22 kg per meter square, American Society Anaesthesiology grading 2, smoke 20 cigarettes per day, at least 40 years, chronic obstructive pulmonary disease, moderate grade. There is gold criteria and it is revised in 2021, and November there is updated guideline also there. Optimized on meter 3 MDI, salbutamol, ipratropium, budesonide. And dyspnea grade 1, no other comorbidity. Posted for planned inguinal hernia surgery. Will you give the case or cancel the case? This is the first question that will come in our mind, that it will cancel the case, yeah, go for the case. So answer is, this is a case, there is history, dyspnea, chronic cough, sputum production, no history of hospitalization for exacerbation. This is important point. No recent history of hospitalization. No history of hypertension, diabetes, thyroid disease, seizure. Smoking, 1 meter dose in inhaler. How much cigarette? There is no history. No history of allergy to any drug. On general survey, conscious, alert, cooperative, no pallor, cyanosis, clubbing, pedal edema, pulse 80 per minute, regular, normal volume, blood pressure 130 by 80 millimeter Hg, mercury, respiratory rate 16 per minute, system examination, airway normal, respiratory system, bilateral breath sound, bilateral air entry diminish. No added, regarding added sound, rhonchi is present, CVS no abnormality, neurological no abnormality, spine normal, all limbs power normal, endocrine normal, GI normal. Regarding investigation, blood investigation, sugar, urea, creatinine, electrolyte, okay, X-ray no abnormality detected. FEV1 by FVC 60%, FEV1 60% predicted, FVC 70% predicted. PO2 65 millimeter with room air, PCO2 40, this is 65, PO2 65 with room air, more than 50. PCO2 40 to 45 millimeter Hg, pH 7.4 by Kamner 22. ECG right axis deviation, virological marker negative for serology. So, and how to write provisional diagnosis? 65-year-old elderly gentleman, ASA grade 2 with BMI 22 kg per meter square, having chronic obstructive pulmonary disease without symptom of heart failure, optimized on meter dose inhaler, posted for planned inguinal hernia repair surgery. This is my provisional diagnosis. How to write it? There is issue regarding the patient, regarding the drug, regarding the surgery, regarding anesthesia. Patient is aged, comorbidity. There is meter dose inhaler, steroid, iatrogenic anesthetic drug we have to given, and anesthesia related issue. There is surgery, minor surgery, no need for muscle relaxation, and post-operative pain is not severe. So our goal is airway optimization, prevent hypoxia, hypercarbia, acidosis, maintain the physiology oxygen transport, age-related concern, pain, early ambulation to early, as we can go for daycare also. CVS, there is hypertension, diastolic dysfunction, decreased adrenergic activity, respiratory system due to age-related problem, decreased CNS response, ventilatory response to hypoxia decline and hypercapnia decline, increase alveolar dead space, closing volume increase. Pulmonary compliance increase, but chest wall compliance fall, leading to total fall of thoracic compliance. Airway protective response decline, more infection, chance of more infection. CNS increased threshold for sensory modality, Post-operative cognitive dysfunction, POCD, is important, more susceptible to depression. There is a renal function problem, decreased tubular function, decreased response, more susceptible to fluid overload, decreased drug excretion, hepatic function decline, musculoskeletal degenerative disease of the spine, so spinal may be difficult. Chronic, so come to the main disease. What is COPD? It is hallmark is airflow limitation. Where is the problem? Large bronchi bronchiole, smaller airway. At which level? It is not fully reversible. Usually both progressive and associated with abnormal inflammatory response to the lung to noxious gas. There is two component. One is chronic bronchitis, other is emphysema. So regarding chronic bronchitis, it is the disease of the smaller airway due to hypersecretion, mucus and inflammation, and there is at least 3-month duration of productive cough for at least 2 consecutive years. This is chronic bronchitis. And emphysema is loss of lung elasticity at the smaller bronchiole. This is distal to the terminal bronchiole. It is irreversible problem. It is irreversible enlargement of the air space and closure of the smaller airway. All this happens, smaller airway. So there is the pathophysiology, noxious agent, inflammation, lymphocyte, macrophage, not fully reversible condition. Pathology, there is cough production, increased mucus, loss of elasticity, airway collapse, increased muscle tone, pulmonary hyperinflation, abnormal gas exchange. There is difference, chronic bronchitis, emphysema. This is blue bloater and this is the pink puffer. This is the airway disease, there is the bronchial problem. Core pulmonary, there is more, there is mild. Go through all this. Lung volume will come to later. Total lung capacity decrease, FRC decrease, all these decrease in case of COPD. This is the hyperinflation, vertical cardiac celoty there is present, there is the diaphragm flattening. These are, if we count the rib, there is a hyperlucent, count the rib, there is a rib count almost 10 or 12 rib count. Chronic arterial hypoxia, pulmonary vasoconstriction, there is pulmonary hypertension, right ventricular problem, hypertrophy and core pulmonary. And another is secondary erythrocytosis, hemoglobin concentration rise. And other problem is weight loss, diet, nutrition abnormality, skeletal muscle dysfunction, right ventricular problem. And there is a risk for MI and angina, osteoporosis, fracture due to movement, due to transport, respiratory infection, post-operative, depression post-operative, and sleep disorder. All this problem may arise. So when we go for pulmonary function test, it is the tool to optimize preoperative pulmonary function. When there is hypoxia at the room air, less than 50 PO2 at room air, home oxygen therapy is required, severe condition, history of respiratory failure, shortness breath, pneumonectomy, lung surgery, difficult pulmonary function assessment, then we should do for pulmonary function test, spirometry. And in spirometry, what we will get? Decrease FeV1 FVC ratio, in decrease if 25% to 75% FeV ratio, and increase residual volume, and FRC and total lung capacity all normal to increase. First one is the important FeV1 ratio, and this is the curve, flow volume curve, emphysema to asthma. And there is few terminology regarding what we do when we assess one patient in bedside. This is bedside PSC. We told the patient to hold the breath. This is a subrasive breath holding test. If it is less than 15 seconds, there is the decreased cardiopulmonary reserve. Expiratory time over the trachea, we by placing the stethoscope, force expiratory time more than 4 seconds, then it is the reduced maximum expiratory flow. This is the match blow at 6 foot and 3 foot. Normally at 3 foot, 6 foot can blow, it is normal. Snyder match. If it is 3 foot, you cannot blow the matchstick. This is the less than capacity, less than 40 maximum breathing capacity. And right respirometer and the peak flow meter, there is the instrument. All these are taken from the gold criteria. There is the gold stage 0 to 4, mild to severe disease. FEV1 FV ratio, this is the 70% predicted, less than 70 to 50% predicted. This is 30 to 50% predicted. This is a less than 30% predicted. And if max in the first second, how much amount he can blow out, this is the FEV1. If it is more than 80%, this is good. If it's 50 to 80%, this is moderate. If it's in the first second, this is the 30 to 50% expired, this is the severe, and less than 50%, this is the very severe. Gold criteria. Dyspnea criteria, grade 0 to 4, there is the dyspnea criteria is there. When we walk, there is no shortness of breath, zero grading. When walk a slight uphill, there is shortness of breath, and moderate state, we have to stop for breathing at own pace level. Normal walking, we have to stop for breathing. And severe case, we cannot walk more than 100 yards after a few minutes on the level. And very severe, too breathless. This is a dyspnea grading. Another previous was the gold criteria. And there is the pink puffer. In case of pink puffer, PO2 more than 60. In blue bottle, PO2 less than 60. And PCO2 is normal pink puffer. This is the alveolar bronchial level problem, pink puffer. This PCO2 is normal, and blue bloater, there is the PCO2 increase. And so pre-operative patient counseling, cessation of the smoking, at least 6 to 8 weeks, improvement of the mucociliary function. It will affect by improved mucociliary function. It will affect by reducing the airway activity, sputum production, and there is increased oxygen carrying capacity of the hemoglobin. At least 6 to 8 weeks to stop the smoking. We have to give bronchodilator, beta-2 agonist, short acting, preferably continue for the time of surgery, nebulization from 2 to 3 days prior to surgery, inhale steroid. In case of severe case, inhale steroid. And intermittent antibiotic for acute episode or increase the problem, dyspnea, sputum production, in sign of infection, you have to start antibiotic. And diuretic in case of right ventricular problem or pulmonary edema, core pulmonary. So mucolytic chest incentives spirometry for every patient we can recommend, and nutritional support, and pulmonary hypertension, there is no treatment by optimizing oxygen. So if there is steroid, what we have to do, dose less than 10 milligram patient taken for minor surgery, for any surgery, less than 10 milligram dose, additional steroid cover not required. We assume that hypothalamic pituitary axis is normal. More than 10 milligram dose for minor surgery to major surgery. For minor surgery, 25 milligram hydrochloride to give, and normal post-op medication. And for moderate surgery, 25 milligram usual dose preoperatively and 25 milligram at induction. Then 25 milligram IV TDS for just 1 day. For the major surgery, 100 milligram hydrochloride induction. This is the usual. I don't know there is anything recently modified or not. Pre-medication, small dose benzosedative at night before surgery, and usual meter dose inhalation, H2 antagonist, antibiotic. Now anesthesia, consent, IV access, resuscitation equipment, drug check, and central neuraxial. You have to write central neuraxial blockade combined with spinal with epidural analgesia, as because this is the excellent analgesia, post-op analgesia, early ambulation, better performance, reduced DVT, all this. And preferred method, regional because there is we avoid airway instrumentation, no risk of bronchospasm, excellent post-op analgesia, but there is problem with high level of block. Why? And increased parasympathetic tone and bronchospasm. And there is hypotension, old age patient, there is diastolic dysfunction already there. All this may cause. And epidural at which level? Subarachnoid at which level? With GA, there is problem, increased chance of bronchospasm due to airway manipulation, intermittent positive pressure ventilation due to may cause rupture of the pleura, pneumothorax, inhalation agent irritant, sometimes cause bronchospasm, increased chance of postoperative pulmonary complication, POPC. So general anesthesia we have to when patient refuse for regional anesthesia, or there is failure, there is coagulopathy, local site infection, and we have to use LMA, low incidence of bronchospasm, and local anesthetic when given before the induction. And standard anesthesia monitoring, post-op complication, age-related, disease-related, atelectasis, pneumonia, delirium, post-op bronchospasm, pneumonia, delayed ambulation, DVT, pulmonary, all these disease-related, and surgery-related is minor surgery, this is rare. And post-operative management, adequate oxygen, analgesia, what you do in SICU? Adequate analgesia, chest physio, adequate nebulization, continue regular steroid dose. And post-operative multimodal analgesia, epidural analgesia, dose you have to mention, oral paracetamol. I have not read about the gold criteria. There is separate, you need the separate video for the separate seminar for the gold criteria. This is recently came out, also gold criteria. So, okay, stop today. Vikas, bolo.
Yes. Yes, sir.